Good afternoon, everyone. This is from AFPI Karnataka chapter in collaboration with International Hematology Consortium. Today, it is my privilege to introduce Dr. Ashish Dhoot. Sir is MBBS, MD Transfusion Medicine and Immunohematology from prestigious CMC Vellore. Thank you, sir, for obliging and actually accepting our request to, help all our family medicine specialists to learn about this blood and component transfusion updates. Sir is currently consultant blood center and stem cell at Healthcare Global Enterprise Limited, that is HCG Bangalore, India. Sir has a lot of experience. Sir is kind of employed in HCG from 2019, but he has a lot of experience as a consultant in transfusion medicine at various other hospitals like Fortis and CMRI. And Sir has a lot of add-on courses in patient blood management from various academies, including some universities from Hong Kong. Sir has recognition from Lions Club of Bengaluru, Sanjay Nagar. Sir was awarded a COVID warrior from ISBTI 2020 from Tamil Nadu. Sir has won Guru Award on Nurses Day in 2019 at Fortis, and Sir is a value has also taken Value Champion Award for teamwork in 2019 at Fortis, and Sir has also won various prizes at various competitions in 3-minute thesis presentation competition held at CMC Vellore and annual research day at CMC Vellore, and also has special interest in Transmedicon. He has won various prizes in various quiz. Sir is also a chairperson of ethics committee from Sankalp India Foundation, and he's also he's been a member of it. And Sir's area of interest is in cellular therapy, apheresis, and cryptopreservation, and development of SOPs and documents for Foundation for Accreditation of Cellular Therapy. I think it's a new upcoming area in our field, and Sir has been a speaker and chaired various presentations at various conferences and has numerous publications. Just to add a couple of them, I've already shared his CV in the group, and Sir is a member of various professional bodies, including Indian Society of Transfusion Medicine and Immunohematology, American Society of Hematology, American Society for Transplantation and Cellular Therapy, International Society of Thrombosis and Hemostasis, and so on. I think it's an honor to have Dr. Ashish Dhoot regarding blood and component transfusion update. Over to you, Ashish sir, without delaying much.
Thanks a lot, Dr. Soumya, for the kind introduction. Good afternoon, everybody. Let's discuss something which you are already been doing. I'm sure you have been transfusing blood and its components regularly. The reason for this session is it helps us to understand what new things have come up in the domain. And let's start. Thank you. We all start with blood requisition forms, and we all know that at least the following identifiers are mandatory: the name, age, sex, and unique hospital identification numbers, because most of the errors which happen in blood transfusions are because of misidentified patients, misidentified samples, misidentified blood bags. So it's really we need to ensure that we enter these things and we focus on entering it correctly and aptly. If you are sending a blood request form to a good blood bank, usually they will also get back to you if there is some discrepancy. For example, there are some diagnoses which require modified blood components like irradiated blood units. So hematology patients or BMT, bone marrow transplant patients, so if they require a irradiated unit, if you have mentioned the diagnosis, the good blood banks themselves will get back to you that, okay, you have forgotten to enter this parameter which should have been there. So it's a good idea that if you're sending to a good blood bank, mention proper diagnosis of the patient. We know that indication for transfusion is different from the diagnosis. Not all dengue patients require platelets. So whichever is the indication, ideally should be mentioned. And if you mention the investigation to support the transfusion, it helps us to prioritize your transfusions. Says we receive two requests, and one hemoglobin is 4 and one hemoglobin is 7 or 8. So we understand that which will go as an emergency one. So it will be helpful for us to support you quickly. History of blood transfusion, if it's also done at a different institution, is important. It helps us in getting two things. One, historical blood group. So as we discussed, most of the common reasons for wrong mistakes happening or errors happening during transfusion is a wrong identification of patient samples or blood groups. So blood bags, these are the common ones. So if you ask a patient what like any prior history of transfusion, and if they have had, and if they have a historical blood group done, it helps us. I'll give some illustrations during the session, so because these are all real life things which had happened, and these help us to identify, okay, understand, okay, what is the gravity of this. For example, in one of our scenario, one of our patients, a blood group sample came to my department. It was one particular blood group. It was from OPD of that patient, say A positive it was, and then the next day when the patient was admitted, another sample came, and it was B positive. When the sample reached to us, we checked, it was B positive. The sample, there was some problem. We did a root cause analysis, and we found that the first day sample, which was collected in OPD by the phlebotomist in the OPD, was a mistakenly labeled sample. Sample collected wrong blood in tube. Sample collected from patient A but labeled for patient B. Now, if such a thing happens, it's extremely difficult to identify what is the correct one, and it can lead to drastic problems. So, because we had a prior history and a new sample has come, we were able to compare it with the previous one, identify that which was a wrong sample. Now, incidentally, it was the first sample that was wrong, but it can be the vice versa also. So, if you get a patient who has been transfused outside or even in your hospital, always it's a good idea to get the historical blood group report and then use that to also mention in the form. Again, we cannot ask the patient what is your blood group, because what happens is there is a memory bias, and many of us forget what is the group, because we see that a lot of patients will come and say that we are identified my group as A, but actually it was O or AB or AB, something like that. So and we find that no, what they were remembering is inaccurate. So we should never ask the patient what is your blood group. We should always refer to the document. The document speaks it for itself. Also, we do not rely on driving license and other such documents or ID cards on blood group, because many a times they will ask us what is your blood group, and whatever we say they write it. So it's not a good idea to rely on such documents, because I've seen such documents having wrong blood groups. Again, asking of when we are asking of historical blood transfusion, we also get a history of adverse transfusion reaction. So, sir, there are some patients who are prone to develop allergies. There are some patients who are prone to develop fever. Every time you transfuse blood, they develop some sort of adverse reaction, because they're prone to develop allergies or fever due to blood. So, such if you are aware beforehand itself, you can take certain precautions, and you can also inform the blood bank, because we will do certain other precautions, for example saline washing of red cells or leukofiltration of red cells, depending upon what is the repeated adverse transfusion reaction happening. One time reaction, it's okay, we understand anybody can have it, but if somebody is having a repeated transfusion reaction, then there is something which is not a problem with just with the blood, not a problem with the just with the blood bag, maybe a problem with the patient also. So this history we can ask. Again, consent of transfusion should be taken when the request form is being sent to the blood bank, not at the time when the blood is finally being transfused. So we all know that there may be scenarios where the blood has reached the ward, and we are waiting for the consent, but the patient's relative has gone out, and now we are asking if specifically the patient is less than 18 years old, and we want a consent to be given from the attender. So now the blood waits for transfusion, and we don't want that to happen. So it's a good idea when you're sending the request, at that time itself we should take the consent. The Jehovah's Witness. So I'm sure many of you might have heard of. So this is a group of people, religious. This is a religion in India. It's a minor religion, obviously, and this broke out from Christianity, and now this religion is present in every state of India. You might not have heard of, but it is there in all of the states. Now, what is the difference in this religion is they do not prefer transfusion of stored blood or allogenic blood transfusion. So if they refuse to give a consent, then you cannot transfuse them, whatever happens. So I have seen a child die because of thrombocytopenia because the parents did not agree for a blood transfusion. The child was there with us for a few days, and because the patient has not given a consent, we took a negative consent. We definitely counseled them multiple times, but there was that we want to follow whatever our religion says, and we have to respect whatever a patient's belief is. So we respected the patient's belief, and then the patient did not survive. Now, if you meet certain patients, I'm sure you one time in your life you may meet such type of a patient. And so if the patient has gone for surgery and the surgery has started, and now when the anesthetist is requiring blood and we are checking for consent, whether consent for transfusion is available or not, at that time blood is there, but the patient relative says, no, no, I cannot give a transfusion consent because we don't want any transfusion. You understand how things can go wrong during the surgery. So it's a good idea to take the consent at the time of request form, at sending the request form to blood bank itself, not at the time when the blood is ready for transfusion. Other points should include whether it's a routine, urgent, or emergency, and what time and place you require. So when I was an intern after my MBBS, my seniors told that if you don't write emergency, blood bank will not issue blood. So it's definitely untrue. Uh, Blood bank has blood for issuing to patients only, and if you write emergency for every patient, what happens is when you have written emergency for the first patient, the blood bank staff stops cross matching the first unit which he has received and starts cross matching for your patient, then the second patient, then the third patient, because everybody is writing emergency. So two things happen. One, the first emergency value is gone because the patient is uh, now we see that every time you this particular hospital's doctor writes an emergency, or this particular ward's doctor writes an emergency, they they are just writing just for the sake of writing, and the blood bank stops issuing blood at an emergency. They will take their own cool time. Second, the first patient for whom the staff was doing the actual request, now that gets delayed unnecessarily because the second doctor, the third doctor, the fourth doctor has mentioned emergency, so the staff keeps on doing the other work, and the first patient's unnecessarily transfusion gets delayed. So you suggest the time, what time blood is required. We always, blood banks will ensure that try to issue blood to you at that time. Specifically, you have to know that okay, for PRBCs we will take about 40 minutes for cross matching, or FFPs also will take about 30-40 minutes for cross matching. So you have to plan for that, and if you ask for 1 hour, 2 hour, 3 hour later, whenever you require, the blood will be available for you for your transfusion at that time. But writing emergency at every place definitely does not make much of a sense. Now, what sample should be included with the request form? So we usually prefer a lavender top, the EDTA, because it's unclotted. It helps us in doing blood grouping as well as cross matching. In case blood grouping was already done and by mistake your nurse has collected, or phlebotomist has collected a serum sample, we can still use that for cross matching, but only if the grouping is already done. If grouping not done earlier, then we will prefer a EDTA sample. Usually the volume is 3 ml, and we prefer that we get the adequate volume. Sometimes we receive 1 ml sample only, and that makes life difficult for us, because then again, like, we may have to request you for another pricking, and that's not a happy thing. So we request that okay, do not underfill or overfill. A little bit plus minus is okay. Even if you give me 2 ml or 1 ml, I will try to cross match with that volume itself. But yeah, we definitely do request to give us a appropriate sample. What happens if you overfill there may be a scenario, if a 3 ml vacutainer has been filled to 4 ml by any mistake, then there may be blood may be partially clotted, partially unclotted, and we may not be able to use the red cells to the best optimum thing. Again, there is a certain sample, the lavender, apart from this lavender sample, the sky blue sample, which is sent for your coagulation tests, the PT, APTT, fibrinogen factor assays, factor 8, factor 9 assays. So that citrate sample, that sample cannot be overfilled or underfilled at all. Even for blood bank, we are still okay a bit overfilling and underfilling, but for citrated samples, this is not at all allowed, because the calcium in that is added accordingly to the amount of the blood which is supposed to be added. And in case you change the volume, the calcium content in the anticoagulant remains a different one than what was supposed to be, and your reports will definitely come wrong. So that test, the coagulation test, has got the least allowed mobility in terms of volume variations, But for blood bank, okay, we are still okay with that. Pediatric samples, we have some microtainers which have half ml capacity, and if you can send for pediatric samples in microtainers, we are convenient with that, because collecting plasma from this is easier for us in half ml also. Again, each sample has to be labeled with at least name and UHID. So one time we had received a Ziploc pouch in which there were 2 or 3 samples. The Ziploc pouch was labeled by a nurse, but the nurse did not have enough labels to stick on each and every vacuum tender which the nurse had sent to us. Only the Ziploc pouch was labeled. So that type of sample, or an unlabeled sample, or a partially labeled sample, that usually goes into the dustbin. We don't even return that that sample back for again repeat labeling. The reason being, we are worried about a wrong sample coming in that Ziploc pouch. Anybody could have added a sample, or anybody could have removed a sample. So we cannot trust, and we want a specifically labeled sample. Without that, that sample will not be returned also. That sample has to be discarded in dustbin. In fact, like I usually tell about my colleague who did a mistake. So what happened was, he was collecting, we during internship again, he was posted in the pediatric ward, and some neonatology patients were there, from which sample had to be collected. Not sorry, neonatology, some pediatric samples from which the blood had to be collected, infant samples. And we all know that collecting samples from infants are very difficult. Sometimes you have to break the needle and collect from that. So he collected 2 samples of 2 babies in the same desk, and it was lying there. Uh, he missed labeling before he collected the sample, and one of the babies kicked one of the sample. This is a true story I'm telling. So he kicked one of the sample, and the sample fell down. Now the senior came and told, okay, we will send the sample for cross match because it's more important. We can send the investigation later for the other baby. So the sample was the my friend told, no, no, the sample which has fallen is of the investigation. I'm sure that the sample which is supposed to go to the blood bank has not fallen, but it was unlabeled. And when it went to the blood bank cross matched, issued the blood was started for the transfusion. Incidentally, the patient was thalassemic. Patient relatives knew the blood group. The blood was started to the baby, and the patients identified, relatives identified, the parents identified, no, no, my patient's blood group is different. Because thalassemics, as we know, that they are regularly transfused. And the patient's relatives came and they made a lot of ruckus that you are given wrong blood. And you understand where it all started. It all started with the labeling of the sample. Incidentally, nothing happened to the patient, but my friend had 1 week of suspension. So we never want things to go bad, and it's always a good idea to label the samples adequately when we are collecting it, because there should be no mixing, and at a time we should collect only one sample, not a different one. Because if a blood sugar comes a different one day, and it comes again a different another day, nobody will question. But if group changes, yes, it's a huge thing. It can be a big problem. So samples have to be labeled, vacuum units have to be labeled at the time of collection, and only one sample to be collected from a patient. uh, a patient sample has to be collected, not multiple patients together. Now, the sample should not be hemolyzed, which can happen in old samples, samples stored under warm conditions, freezing temperature, or forcefully aspirated samples. Because when we are checking for RBC and it's hemolyzed, then it may give us inappropriate result. How it should be stored, how it should be transported. So we have different, some cellular components, some plasma components. Let's discuss them. So packed red cells, they are stored at 1 to 6 degrees Celsius, and transportation temperature is 1 to 10 degrees Celsius. It's a common practice that when we ask how are you transporting blood, people say that they agree that it has to be transported in an insulated box, but they say, okay, we will use an ice pack. But we suggest it's better to use a cold pack, that is ice. Always we know as a temperature has a less than 0 degrees Celsius, whereas we want 1 to 10 degrees Celsius. So unless until it's a interstate transportation or something, or we are transporting 10 blood bags in a single box, and you have to maintain that, it's always a good idea that when you're transporting 1 or 2 bags, transport with a cold pack. The gel pack has to be stored in the 1 to 10 degree part of the compartment of your refrigerator, not in the ice compartment, because when we are issuing blood, we are issuing it of good quality. But during your transportation and temporary storage in your ward, for say half an hour, 1 hour, 2 hour, if it's showing at say less than 0 degrees Celsius, it will induce hemolysis in the red cells, and which we don't want. So it's a good idea to transport in cold packs rather than ice packs. For other cells like platelets and granulocytes, granulocyte rich concentrates, these are used for our neutropenic patients, granulocytes. So that storage is at room temperature, 20 to 24 degrees Celsius, and the transportation is also the same. For other components of plasma, like fresh frozen plasma and cryoprecipitates, these are frozen. We have minus 80 degrees Celsius freezers. We have minus 20-degree freezers. So depending upon what that we store at very frozen conditions. But while issuing it to you, we will thaw it. We will melt the ice and we'll issue. So to summarize, I will say this chart, we should transport every blood component in cold pack. It's a good idea to avoid ice packs unless and until you're transporting it across the state, and where you will require a longer transportation. And then also I will say that we should not use ice pack like that in direct contact. It should not be in direct contact with the blood bag. For platelets, we cannot transport in the same box. When a patient requires red cells and platelets both, which sometimes happens, they have to be transported in individual containers, because platelets will be transported at room temperature. Now, after the blood has reached your ward, there are certain things which you need to check. You have to check or match the product which has come with the product summary with the patient's data. Now, this has to be done from the patient's file and the tag before spiking the bag, not after spiking. So you have to check the product's name. You have to check if you have asked for FFP, but I by mistake have you issued you RDP, then it's not acceptable. You have to check the patient's full name. If so, there was a scenario again in one of the places I was working earlier. So there were two patients, Ramesh A and Ramesh S. This is again a true incident. So both the patients were in the same ward, uh, and both the patients, doctor had mentioned that okay, we will require blood. Reserve the blood for this patient. Now Ramesh A actually required blood, and Ramesh is like blood came from the ward, from the blood bank to the ward. Now, nurse of Ramesh S, the second nurse, saw the patient's name, remembered, yeah, my patient is Ramesh. I myself have written the requisition in the morning. She took blood of Ramesh A and started the infusion for Ramesh S. What mistake she did? She did not check the patient's full name. She did not check the UHID of the patient. Had she checked the both, then this would not have happened. And luckily, the blood group of the patient was same, so it did not cause a problem. But had it been different, because blood banks also are humans and working humans, and we have scenarios where wrong blood was issued. Patient was O negative, O positive was issued by a technician by mistake. And so if we identify it on time, then only we are safe. Otherwise, once you have started, then problems may come up. For the Ramesh patient, incidentally, the blood groups were same for both the Rameshes, God's grace, and nothing happened. But again, yeah, it was a difficult day for the nurse after that day, on that day after the transfusion. Also, the doctor also missed checking, and it again becomes very important that it should be checked. We had another scenario where blood was issued, where here the name was also different. UHID was also different, but the blood bank staff made the mistake of issuing the wrong unit. The nurse also made the mistake. Okay, she did not. She saw some name is there in the label. She saw the name is there on the cross match request, but she did not verify it in the patient's data. That when I'm transfusing to patient A, it should be only for patient A. So they took patients like they wrote the patient B's data in the file in the paper and started, and the doctor also missed. And they all, it was a like a serious event in one of the hospital I know, and they transfused. Incidentally, blood group was O positive, though the recipient was not O. Recipient was A positive. But we know that packed red cells, it can be given O positive or universal donor. So patient did not had any transfusion reaction. But had that happened that day, it would have been a major problem. So these are all real incidents happening in some of the hospitals, which I know my colleagues are working. So these are real incidents, and if we do not check it on time, then we can actually miss the bus. You have to check the unit number of the product, match it from the patient's summary. If I have given you summary which has mentioned 112, but I've issued you 113 unit number, then obviously you know that there is a problem. You cannot transfuse that unit. Date of expiry, yes, it's important to check. One more thing, many a times what happens, we face sometimes delays. So in our blood bank, we try that there is no expiry of blood. Even like we try our best that not a single unit expires. And even on the day of expiry also, we issue the blood. Now, the blood expires when the date changes. For example, if today's date is 27th of March and the expiry of the blood is on 27th of March, the blood is expiring on 28th when the date is changing. This is like difficulty what the drug inspectors have created it for us, that ideally it should be on the date when the date has changed, but we are supposed to write on the last day that today is the date of expiry. So when the date changes from 27 to 28, then only you cannot use on 28. But we try that if we are issuing on 27th, we call them, we inform the nurse that, and the doctor that blood is of today's expiry. It has to be finished by midnight. Do not allow the date to change. There may be some concerns. What about whether the product is going bad or not? Because we are issuing it, we are using it on the last day of expiry. No, the blood has been validated to be used till the date of expiry is there, till the shelf life has been validated. And so internationally, these dates are available and we are allowed to use even on the last day. We definitely try that we do not issue on we do not wait for the blood to be issued on the last day. But there are certain scenarios like a O negative or a red unit, which is required, AB negative. So we don't get regular patients for that, and we don't want any blood to be expiring on that because we understand the pain of a blood donation. Volume of the bag is important for pediatric patients. If the patient can communicate, we should ask the patient his or her name, and the historical blood group again should be verified from the document. Again, it should not be checked from asked from the patient. Yeah, we check the patient's tag. Sometimes hospitals have a tag where UHID is there. So if it's there, we should check it. The final check must take place next to the patient, not at the nursing station, because at the nursing station there may be so many files of different patients, and that may cause confusion. So better we go to the patient bedside and we check it there so that there's no mistake. And we should verbalize it. When we are verbalizing it, the our alertness levels, as we know, is increases and chances of mistakes are less. And the patient is also hearing his or her name. If there are multiple bags, for example, random donor platelets, there may be 3 or 4 or 6 bags, whatever. If there are multiple bags, then we understand that each bag has to be matched. And in case the checking process gets interrupted, it has to start again. At least two people identify it, the nurse who is transfusing it and the doctor who is verifying it. Both have to verify it. Again, a true story. So what happened was a blood bag was issued for a patient, and for the surgery, the patient did not was not transfused in the surgery in the during the surgery in the OT. The anesthetist suggested, okay, let us transfuse it post-op because the surgery was over. And when it was night shift of the nurse who had gone about say 8 o'clock, 9 o'clock, the doctor also went. They verified the bag, but while they were transfusing, they saw that okay, some antibiotic infusion is going on. So they paused. The nurse kept the blood bag in the refrigerator, and after half an hour, when the nurse came, she started the transfusion. She went back. Later on, after 20 minutes, when she comes, the patient's urobag is cola colored. The patient whose transfusion was going on, her urine was coming as cola colored. It was dark colored. And that's a pinpoint, that's a highlight that patient is having acute hemolytic transfusion reaction. So what was the problem that day was when the nurse kept the bag, there was another bag in the refrigerator. The nurse took the bag and she told, I have myself kept the bag. So she took and she started the transfusion. She missed checking the last point. If the checking process is interrupted, the last point in this slide, if the checking process is interrupted, it must start again for that particular bag. So the nurse should have checked. It was a different patient, different UHID, different blood group. Everything was different. It was a new joinee nurse, a fresher nurse, and she did the mistake. Now, for that reason, we are supposed to ensure that we train our nurses also in good practices. And if they're transfusing it again, by any chance, better, okay, you call me, I'll verify it also, you also verify it, rather than, okay, we have verified it, let the nurse start it. Anyways, we have checked it. No, because what may happen is, say, suppose one bag was there, some other nurse might have kept it, and another nurse might have removed another bag. So for two patients, somebody is keeping, somebody is removing. Even someone else's mistake can come to my head. So better we should verify it. And you understand the patient had to be shifted to ICU that night. The ICU in charge is being informed. The treating consultant is being informed. The blood bank consultant is being informed. The nursing in charge is being informed. The hospital's medical superintendent is getting information. Patient's relative is being informed that patient is getting shifted to ICU to understand what that nurse might have faced that night and the next day morning also, and the duty doctor who was there. So a lot of things can cause problems. So it's a good idea that when you're doing something which is important, let's double check it. So it should be a perfect match when we are transfusing blood. Now, the blood has reached the ward. Apart from that, what will you check? You have to check the integrity of the bag, that whether the bag is leaking or not, and that has to be checked before the bag is piped. For example, how do we check the integrity of a milk bag? We just press it. The milk is leaking or not. Similarly, for blood bag, you check it. You press it. It's leaking or not. But if you check it after the bag is spiked. A milk bag is sold. The shopkeeper will not take it back. Similarly, blood bank will not be responsible for the bag which you or the nurse has caused a problem. So we have to check it before the spiking of the bag is done. Unusual bulging. So we have to check whether any unusual bulging is there bag in the bag or not. So we understand that all blood bags will have some air in that. And that is acceptable. It will not cause any air embolism. Like our IV fluid, when we infuse a little bit of air on the top, the liquid goes below, and that does not cause air embolism. What we are worried about is that the excess air, why it came. It may occur due to bacterial growth in that. If by mistake, if the technician who or the phlebotomist who collected the blood, or the nurse who collected the blood in the blood bag, did not clean the antecubital fossa of the donor appropriately, and that led to spreading of the infection in the blood. And we know that blood is a very good culture media for bacteria, and the blood is being stored for more than a month in the blood bank. So definitely the bacteria will get a chance to grow and produce carbon dioxide because of anaerobic respiration. We are definitely not worried about carbon dioxide. We are worried about why that excess air, why that anaerobic respiration has happened. So in case there is a doubt, before you spike the bag, contact the blood bank, because after you have pricked, all the air moves away. So if any abnormality, contact the blood bank. A little bit of air, I told, is normal. It should be there. But anything which is too bulging, like a food can which is too bulging because of the bacterial growth, anaerobic respiration, should raise a index of suspicion for us. Again, discoloration of the bag, what we are talking about, the blackish discoloration, which can happen because of the hemolysis due to bacterial growth. We are okay with mild back-to-back variation of the yellow color of the plasma, or mild back-to-back variation in the red color of the PRBCs, because different donors will have different hemoglobin. There is a bit of variation which may be there. We are not worried about that. What we are worried is blackish discoloration of the bag, temperature of the bag. So if PRBCs are warm on receipt, we have to check what time it was issued from the blood bank. So why we are so much obsessed with the temperature? Because we have in the previous slide also we have mentioned, and again we are coming back to temperature. So what happens is, normally a cell should die if it's being stored for more than a month, because we are not feeding the cell. But these red cells are not dying. They are remaining as fresh. We want them to remain as fresh as it was collected on the day of collection. So how do we do is, what we do is we push them into hibernation by cooling it, so that the enzymatic activity of the red cells are down. They don't consume any calories when they are being stored. Whatever food was there when we collected it, those food itself should remain. Otherwise, they will consume everything and then they will starve to death, and you will get a hemolyzed unit. So this is something like polar bears again, like they're eating a lot during their winter months. There's the good months, and when they go for hibernation for 3 months, where they do not move at all, they are hibernating. So the heart rate goes down to 20 beats per minute, brain not working, muscles not working. They use their fats and they come back all fresh to eat the thing which is again available after the hibernation, because nothing was growing in those -40, -50 temperatures outside. No plant is growing, no animal is there which they can eat. So we are doing the same thing for our PRBCs, and that's why they're stored at particular temperatures. Once it's outside and the temperature has started increasing, now the red cells will come back and they will start consuming the food which was there in the bag. After, if there is a too much of a delay, then they again go for hemolysis again, which we don't want. So again, a true story. I received a patient from the emergency of my hospital that they have been referred from a different district. They had taken discharge on risk, and they had bought two blood bags from that hospital to our hospital. And because that hospital, they had indented the blood, they had requisitioned the blood, but they could not transfuse because patient had taken discharge on risk, and they bought it with to us. Incidentally, they had bought it in plastic bags. And when we checked the temperature, they were warm. They were issued the previous day. So 1 day old prior blood, warm on receipt. I'm sure that nobody of you will be happy to transfuse that unit. So we have to discard those two units painfully. So we discarded them, and we had to give fresh units to the patient again. So what should have been done? Ideally, when patient is taking discharge, even on risk, but they have paid for the today's date, correct? So if they paid for the today's admission charges to the hospital, and the blood has been also been paid, the charges have been paid, let us start the transfusion. Let us finish the transfusion and then send the patient, rather than sending the blood with the blood bag. And nobody transfuses blood in the ambulance. So that's also a myth that people will start the transfusion. Ambulance staff will start the transfusion. When the doctors are afraid to start the transfusion in the ward, why? And they are giving that, not afraid, they are giving that responsibility. The ambulance there is no doctor in the ambulance, or if some reactions happens in the ambulance, so they will not do it. So they will again tell, okay, when we reach the new hospital, you transfuse it there. So it again gets delayed unnecessarily. So so what I prefer is when you're sent there, when you are discharging a patient on risk, DAMA is there, against medical advice. So you finish the blood whatever is there, and then you send the patient. Uh, and if blood is being shared from one unit, one hospital to another, it should be transported in an insulated box under appropriate temperature condition. If there is a clot in the bag or filter or tubing, definitely the clot has got stuck, but you cannot transfuse. You have to send it back to blood bank. Blood bank will do the needful now. They will replace the bag or whatever. And again, you have to return the bag with the blood set. If you remove it, which happened with one of our nurse, he removed the set because there was some confusion in the label, and all the blood spilled. The unit could not be used further, even though the unit was correct. There was no problem in that. There was some confusion in the labeling, and there were 6 RDPs, and all the other 5 RDPs are also now like stained with blood. All the labels gone, paperwork gone. So when somebody is returning, it's a logical idea that it should be returned with the blood set, because this all these incidents have happened real life. We are not supposed to store blood, any component in the ward refrigerators, because in blood bank they are stored under very controlled temperature conditions. Our blood bags are refrigerators are calibrated, while the refrigerators in the ward may not be calibrated, and a lot of medications are kept. So nurse will come and open the refrigerator for patient A's medicine, then patient B's medicine, then patient C's medicine. Temperature is fluctuating, which we don't want. Till the time the blood is spiked, it should be stored in the same transportation box in the same recommended temperature condition, because we understand that there may be some delay. You are working on something else, or the nurse is busy, is not available. So whatever, till the time it is being spiked, keep in the transportation box in the recommended temperature condition. And if there is any unexpected delay due to unavoidable circumstance, the patient is very sick now, you cannot transfuse for 2 or 3 hours, the patient has gone for MRI, and if you have the blood bank within your premises or nearby, we I because in the place where I work, the blood bank is within the unit, within the hospital. We receive it back and we store it temporarily in the blood bank. But in case that is not available for your institution, suppose, then yeah, you have to store it in your refrigerator for 1 or 2 hours if it's there. But if it's there for long duration, say 4 hours or 5 hours, then it's preferable to return it to the blood bank. We'll collect it once it's required again, when the patient is again fit to be transfused. Now we check the what's the consultant's notes for the type and the number of components required, any specific advices when to transfuse. So this I remember, I used to work in ICU at a time, and the consultant had given a note that okay, transfuse 2 FFPs in the morning, 2 FFPs in the evening. And the nurse thought, okay, 2 in the morning, 2 in the evening, let's purchase all the 4 FFPs together. Now you see, these are frozen products. These are stored in the blood bank at -20, -80 degrees Celsius, depending on the freezer. So these are frozen products. At as they are warmed up, some factors like factor 5 and factor 8, these are level temperature level factors, and they start coming down, and so that can cause problem. So they should be frozen and should not be thawed unnecessarily. So the doctor had told 2 in the morning, 2 in the evening. So nurse got all the four together, because who will again get and write another request form and get another one, and somebody has to go to the blood bank. So she stored two in the refrigerator and she transfused 2 in the morning, 2 in the evening. So when I came to know of that, I suggested this should not be. Uh, this should not be. We should get only two. We should not store in the refrigerator. The doctor has told not to store in the refrigerator because it's a frozen product. Now, so don't store in the refrigerator. So the next day, went to the bedside, and while I opened the patient's drawer to take out the paper, I saw two FFPs again lying there inside the drawer. So when I asked what is the problem, nurse told, no, no, you told her don't store in the refrigerator. So I have stored in the patient's drawer. So these are all like two incidents and should not happen. FFPs are frozen products to be stored frozen. When we want to transfuse, we should take at that time, thaw it and transfuse it. Evening again required, we'll take it again. Nobody buys the ice cream and keeps it at room temperature and then eats it in the evening again. Consent, yeah, if consent was taken by your colleague, if you have taken the consent, no problem. But if somebody else has taken the consent during transfusion again, it's good idea to re-verify it. If you had not asked for a history, and again before transfusion, it's better to again ask for a history of reactions, which we had discussed earlier. Always we have to use a blood set with standard filters for all type of components. So sometimes some people ask like, why are you using a blood set for a FFP when it's not being used for normal saline? So see, both are liquids. Some people will say, so when I asked this question to nurses, nurses told them the FFP is viscous. So that's why you have to transfuse with blood sets. You cannot transfuse with IV sets, but that's again a wrong thing. It's not because of the viscosity of the blood. If I'm giving and if blood is viscous and the filters are there, it will even actually slower down the transfusions. So we are using filters for FFPs because FFPs are the ones that have the clotting factors. They will coagulate also. And only thing, the clump will not look like clot will not look like red. It will be straw colored. So whatever it is for any blood component, it standard filter has to be used. A blood set has to be used, not IV set. Whatever happens, the blood has to be spiked in a sterile way manner without touching the sterile parts of a blood set. So there are two sterile parts of a blood set. One that goes inside the blood bag, the spiking end, and one that goes inside the IV cannula. So these two are the sterile parts and cannot be touched even with gloved hands, because your gloved hand has touched so many parts. Many a times when we open the blood sets, we find that the needle is not attached to the blood set. The needle is detached, and the the part which is supposed to go in the IV cannula is separate. So what I suggest is, before you open the blood set, bring the needle, or if it's capped, no problem, but bring the needle to the spiky IV cannula end, cover it, and then you open it, so that when the blood set falls on your desk, it's not touching anywhere. It's still remaining sterile. How to prick the bag? So first, like after definitely you have verified everything, the patient details, and definitely whether the bag is leaking or not, clots and all, any visible clots, any visible discoloration and temperature and all, you have verified. Now we suggest to keep the bag on a firm surface, not to hold the bag in your hand while you are pricking. The reason being, these are not bottles. So the bag will bend on its weight, and when we are pricking the bag, there will be, it's designed to be of a firm nature, strong nature, and you have to apply certain force to prick it. And when we are holding it in our hand, the sharp spiking end of the blood set hits the bag's walls, and the bag may start leaking. It has happened with many of our nurses. I've seen that they did it, and then they come to us what to do now. So first is prevention. Let's keep the bag on a firm surface. Open the port of the bag first, not the open of the blood set. The spiking of the blood end of the blood set is covered with a cap which can be easily opened, but the blood bag's port is difficult to open. We have to twist it and open it. So first open the blood bag's spiking port, then you open the blood set spiking port, and with a uh, uh, we have to have a what to say a twisting motion. We have to pick the blood bag in a horizontal position with the bag kept on a firm surface. Now, if a nurse comes and tells that by mistake she has pricked and the bag's wall has been pricked, now what to do? How to handle that? So in such a scenario, in such a scenario, we have to apply artery clamps. So if you send it to blood bank that okay, replace the bag for me, there are two problems. One, while the blood is being transported to the blood bank, it will leak. Second, so the volume will be less and it will cause messy things. Second, the blood bank will not accept the responsibility of the leakage. If it is issuing you a different unit, it will bill again to the patient, and the patient will again create problem to you that okay, why a second unit is being issued, so second unit is being billed to me when I was actually transfused one unit. Also, we know that we don't want to waste the donor's blood, because about 300 ml or 350 ml of blood is there in that bag, which we don't want it to be wasted. What we suggest is use two artery forceps, apply it from two sides of the blood bag, and with that, the flow of the blood can be stopped. Whatever blood is there inside is still sterile. Whatever blood has fallen down may be unsterile, but whatever is still there in the bag is completely sterile. So suppose 5 ml has fallen down, but the remaining 300, 350, 400 ml is still inside the bag. So let's not waste that. Also, a problem about air entering. So we don't have any problem. We know that it will not cause infections, because even when I'm sure many of you might have pricked the saline bottle when you are giving saline and to allow some air inside, and that did not cause any infection to the patient. Only thing, the bag becomes an open system and it has to be used within 24 hours after that. So that anyways we are going to use. So apply two artery forceps on two sides where the leaking has started. On the different port of the blood bag, spiking port, you attach a new blood set and collect blood from there. better not to remove the old blood set so that it does not leak. The drip set should be half filled. We all know that if it's completely empty, air bubbles will keep on disturbing. If it's completely full, we will not be able to see the speed of the blood which is going. IV cannula should be patent. Again, it's my personal experience. During my internship, I connected the blood bag and I went. And after 1 hour, I came, the blood is still there. It's not going. So because the blood is viscous, it's a viscous fluid, and we have to ensure that it's going at adequate speed. If it's a good idea if even like if the IV cannula is slightly a few days older, 2 days older, then we flush the fluid IV cannula with saline and then with a with a syringe and a saline, and then we attach the blood to go faster again. It's a good idea to take a second look after 10 to 15 minutes of starting the transfusion for two reasons. One, whether to confirm whether the blood is going adequately or not, because if it's not going, we have to do certain things, and whether reactions are happening or not. So you remember that patient who developed post-operation, who developed the cola-colored urine in the Euro bag. So that you remember the discussion we had that it was a wrong blood which was attached. So if a patient has a reaction, it's a good idea to take a second look after 10 to 15 minutes. The nurse can check the vitals, pulse, BP, whatever the vitals we are checking, and pulse, BP, temperature, and SpO2. These are the few vitals, and just ask the patient, are you okay or not, something. So we understand, okay, patient is all comfortable, there are no reactions happening, because a little amount of blood can cause reactions. We are not supposed to give any medication to the patient except emergency drugs and in OT, because if any allergy happens to an antibiotic or to any drug, which can happen on the second, like patient did not have any allergy during the first use of the antibiotic, may develop in the second, may develop in the third usage. So if any allergy happens or some reaction happens, we will not be able to identify, discriminate whether the reaction was due to the drug or the reaction was due to the blood transfusion. So if it's a good idea, it's a good idea that do not give any medication during blood transfusions. In case you have to still give a mandatory some medicine, that okay, a sepsis report has come, a culture bacterial culture report has come and the patient is having some infection, so we know that the septic bundle state that we have to start the antibiotics as quick as possible. So we have to pause the transfusion, give the medicine whatever you have to give the antibiotic or drug whatever you have to give, flush the line with normal saline, wait for 15-20 minutes, and then restart the blood, so that we understand that if any reaction was supposed to happen, it would have happened already by that time. Again, similarly, during fever, we try that we should avoid transfusions. It's not that the blood will hemolyze, definitely not. The problem is if we'll not be able to distinguish the baseline fever from the transfusion reaction. And if that patient already had 101 fever, now it becomes 103 after giving blood, whether it's because of the baseline problem or because of the transfusion reaction for which the blood is being given. That's why during fever, we try to avoid transfusions, because fever can happen in acute hemolytic transfusion reactions, which is a dreaded reaction for us. Now, in patients who have been having fever regularly, it's a good idea to check the patient for fever before the blood is being procured from the blood bank. So you can send a requisition to arrange a blood, and you are getting it after 2 hours or 3 hours or 4 hours or in the evening. So when you're getting the blood at that time, before you're calling the blood bank, okay, issue the blood for me now, verify that the patient is not having fever to avoid confusions later on. In case after the blood has reached the ward, now the patient develops fever, what to do? So we first feed the patient with paracetamol, wait for half an hour for the temperature to come back to normal levels, and then we start the transfusion. In case any IV fluid is going through a three-way cannula from a same IV cannula, or a three-way stopcock through the same IV cannula, we have to avoid calcium-containing fluids like Ringer's lactate or Hemaxil, or hypotonic solutions like 5% dextrose, because blood is going slowly, these fluids are also going slowly. We know that why the blood is not clotting in the blood bag, because we have an anticoagulant which is preventing the blood to clot, and that anticoagulant is working by removing calcium. So we use citrate in the blood again, and that citrate ensures that patient's blood does not clot inside the bag. Now, if you are using calcium, it may cause blood to clot in the IV cannula, and then you have to change the IV cannula, which is again a headache for you. Or hypotonic solutions will cause hemolysis again. If it's going from the different line, I don't have any problem. If it's going from, say, a different line of the central lines may have 2 or 3 ports. So if it's going from a different port of the central line, no problem, but should not go from the same port. Similarly, we should not warm a blood unit. So during my internship, it was very common for us to warm the blood unit. And when I asked the new nurses who joined my hospital that in different other hospitals, they still many a times they warm the blood bag. And it's not a good idea to warm the blood bag. We already discussed that the blood should remain cold when it's being transfused. If the patient feels cold, we have to cover the patient with a blanket, not the blood with the blanket. Some people ask, okay, keep the blood bag next to the patient's tummy so that the blood becomes warm. Or some people will leave it at the room temperature on the surface for, say, half an hour, 1 hour, or cover with blanket. These are all outdated practices. It's not supposed to be followed. There is a long blood set which warms the blood as the blood is coming to the patient. That much temperature is enough when we are giving blood to the patient. I'm sure none of us must have seen any patient developing pneumonia by being transfused cold blood. Correct? It never happens. So we are supposed to give cold blood. We are not supposed to warm up blood when we are transfusing it. We are supposed to start the transfusion within 15 minutes of the blood reaching the ward. If we can start even earlier, the better it is. The earlier, the better. We had and under special circumstances, blood warmers can be used. Now, these blood warmers look like these. These are calibrated equipments. If it's showing calibration means if it's showing 37, it will be around 37. It will not be around 47. So plus minus 1 or 2 degrees, maybe up and down, but not much more than that variation. And the blood bag is above. It's not visible. The blood set is coming and it's winding around this blood warmer, and then the blood which is going inside the IV cannula. So only the blood which is reaching the patient is getting warmed, not the entire bag is getting warmed. And when do we use these warmers? These are used in rapid, large volume transfusions. These are used because that can induce hypothermia. It's used in exchange transfusion in neonates because we know neonates cannot have shivering, cannot make themselves warm again. And in patients with clinically significant cold agglutinins. So these patients, again, blood bank will tell you that there's a problem, or if it's a hematology patient, usually this happens in hematology patients, some of the hematology patients. So then again, it's a specific advice given that that blood has to be warm because blood will cause problem if it's being given cold to them. So what should be the rate of transfusions? For packed red blood cells or granulocytes, we start at 1 ml per minute, 1 to 2 ml per minute for the first 15 minutes under careful monitoring. And then we increase the rate gradually so that if any reaction happens, we'll be able to identify it then and there. Finish the PRBC transfusion within 1 hour, 30 minutes to 2 hours under normal scenario. That will be about 200 ml per minute per hour. So we have to finish the transfusion within 1 hour, 30 minutes to 2 hours. When should we granulocytes are longer, like they are more ml, their volume may be more 350, 450 ml. So we have to transfuse it slowly. For PRBCs and granulocytes, the maximum allowed duration, but not the preferred duration, is 4 hours. Where a lot of people I find that they transfuse over 4 hours, 5 hours also, which is not the correct method. Whom should we give slow transfusions? It should be for volume sensitive patients, chronic kidney disease, cardiac compromise, volume overloaded. These are patients whom it has to be given slow, and a diuretic has to be used during transfusion. Not for everybody. For FFPs, fresh present plasma, single donor platelets, these are 200 ml capacity bags, and 200 ml is the content in them, and we transfuse them over 20 minutes. It's easy to remember, 200 over 20 minutes. So we have to invert them gently over 10 to 15 times before use so that they get mixed properly. RDPs are random donor platelets, the small volume 40, 60, 70 ml bags. So these are given in bolus. Cryoprecipitates are also transfused in bolus. Only the PRBCs 1 hour 30 minutes to 2 hours, and maximum for volume sensitive patients 4 hours. During major hemorrhage, rapid transfusion of PRBC also has to be done. I have transfused one full bag of PRBC in 5 minutes. I was working in OT, and we have to be but that is under appropriate clinical and hemodynamic monitoring. For neonates and infants, this is the typical rate, 5 ml per kg per hour. And for other units, like apart from PRBC, it's 10 to 20 ml per kg per hour. Platelets can be transfused sometimes of different groups. RDPs I'm talking about. So if you are transfusing RDPs, they may be of multiple groups and not always of the same group specifically. If you are transfusing them, they should not. All the RDPs can be transfused through one blood set, but that blood set should be separate from the one we are transfusing PRBC, because there the grouping may be different, and it can be a mixture of A positive 1 bag, B positive 2 bags, O positive 1 bag. but PRBC has to be of the same group. So we have to use a different blood set if for platelets, but that can be used for the same. In fact, if I'm transfusing three PRBCs back to back, I can use the same blood set. I don't need to change the blood set in between. We have to monitor the pulse VP temperature. If SpO2 can be monitored, even better. But even if not monitored, it's okay. I have to take a general look at the patient's appearance when we are transfusing it, so that because some patients cannot communicate their distress or pain, specifically unconscious or semi-conscious patients or pediatric patients. Monitoring. It's again a common question. When should we monitor uh, the patient? So vitals have to be checked 4 times for every blood transfusion. So I mentioned immediately before starting the transfusion, but I would like to mention that it should be within 30 minutes of starting the transfusion. So when we are sending the request to the ward, at that time itself, we can verify it. That when we are sending the request to the blood bank from the ward, that okay, issue the blood, then we can check. And if it's within 30 minutes, we can starting, that temperature is valid. Next, we saw that reactions can happen within 10 to 15 minutes of starting the blood. So we check at 15 minutes. At the end of transfusion, no need to check in between every hour, every half an hour. No, not required. Directly check at the end of the transfusion and 1 hour after the end of the transfusion also, because reactions can happen even when the transfusion is over. It is best avoided to return the blood back to the blood bank by taking care that the blood is received from the blood bank only when the patient is best fit to be transfused. Patient is not having fever, patient is not going for any investigation, no ongoing or planned medication, adequate nursing staff are there. If you're getting the nurse when during nursing handovers, we know they are double in number at that time, but not functionally. They're just in number because they're taking handover. They're not taking care of the patient. Consents are signed beforehand. So this is the way by which we can avoid returning the blood back to the blood bank. Many blood banks may not accept the blood also. So it's different institutions have different policies. Our blood bank definitely takes it back because we don't want any wastage of blood. But it is officially it's returned up to 30 minutes after it has been issued from the blood bank, provided it has been kept cool. If you warm it, then the unit becomes compromised, and I cannot then store it for 3 4 days and again need to issue it to another patient. So it should not be warmed when I'm issuing the unit. Uh, how much should be the dosage of blood components? So PRBCs, they raise the hemoglobin of an adult person by 1 gram%. Random donor platelets, one unit raises the platelet count by 7,000 to 10,000 cells per microliter. And we can calculate with this that if my goal is say 20,000 increment or 30,000 increment, I can calculate how many RDPs I require in a normal scenario. Fresh frozen plasma, 10 to 15 ml per kg, we can use in obese patients true body weight or lean body weight, not the actual body weight. So each bag has about say 200 ml at an average FFP. So you can calculate how many bags of FFPs may be required for you. Volume is less important in platelet RDPs. It's the cells per microliter which is more important, and this is the one which we are having. And I'm telling about random donor platelets, not SDPs right now. Cryoprecipitates, again, most of us do not know the dosage of cryoprecipitates. So one bag per 10 kg of patient weight, if fibrinogen value is between 100 to 150 per international units per microliter. In case the fibrinogen value is less than 100, then we have to double the dose. So if a patient is 50 kg and the fibrinogen value is 125 and the patient is bleeding, if the patient is not bleeding, then we usually need not transfuse cryoprecipitates. We are not treating numbers, we are treating the patient. If patient is not bleeding, we are not using. But if the patient is bleeding, then one bag every 10 kg. And if the fibrinogen value is say 90, then double the dose. In small children, less than 20 kg, it's 10 to 15 ml per kg up to the adult dose. I will also mention one thing that for this is the dosage as such, but in pregnancy, the fibrinogen value is different. In pregnancy, it's a hypercoagulable state, and so we consider that the normal level of fibrinogen in an adult is more than 150, but in pregnancy, we consider normal level is more than 200. So even if it's between 150 to 200 and patient is bleeding, we have to transfuse the patient with cryoprecipitates. If it's say 250, obviously, then it's not required. So what are the transfusion triggers? At what level should we start the transfusions? So for packed red blood cells, for general patients, including surgeries, post-operative patients, infants, except neonates, because their values are different. the cutoff general is 7 gram%. Blood can be reserved. So suppose you are expecting that a patient's hemoglobin is 8 and there may be intraoperative bleeding or patients or there may be low initial hemoglobin value like 8 or even the hemoglobin is say 10, 12, whatever, but you expect that intraoperative bleeding is there, you may reserve it at any level, no problem. But when you're transfusing it, the cutoff as per the international guidelines is 7 gram%. For bone marrow transplant patients, it is 8 gram%. We should not transfuse higher than that. So once I had a doctor who was working with me in the blood bank, during my training days, and the patient's hemoglobin was 9 or 10. Yeah, it was 10. And the doctor, somebody had requested blood, and the doctor allocated the blood. So I asked the doctor, why are you issuing blood to this patient? So he or she told that she told that I want to correct the hemoglobin value. A hemoglobin value is not normal. Not 10 is not normal. But we know that this is not the correct thing. There are cutoffs. We are not trying to achieve normality by blood transfusions because transfusions have got their own inherent adverse effects. We are trying to just save the patient during that acute period. We are not giving a transfusion will not correct the thing for lifelong. If iron deficiency is a problem, we have to correct the iron deficiency, not transfuse blood at 10 for autoimmune hemolytic anemias. So these are the patients where patients develop hemolysis on their own, even without transfusion, they are hemolyting. And when you are giving blood, whatever cells you are giving will be incompatible to the patient because the patient's own antibodies are fighting against the patient's own cells. And they, if you are giving from outside, they may also have that. So we keep a cutoff of 5 gram%. Normal patients are 7, transplant patients are 8. But for autoimmune hemolytic anemia, if the hemoglobin is 6, we will not transfuse because the more you transfuse, the more hemolysis may happen and the hemoglobin may drop down even further. But yes, if the hemoglobin is 5, we cannot wait. We have to transfuse because if it goes too low, then the patient will have cardiac issues and may not survive because of anemia. We don't want to kill the patient due to anemia also. So a sharp cutoff is required. For beta thalassemia majors, hemoglobin level should be maintained at 10 to 12 gram% by periodic small transfusions because the children's growth phase is there. That should not be compromised. This level cannot be corrected by whatever iron you give, folic acid, vitamin B12, whatever protein we give, it cannot be corrected. So we have to pull this hemoglobin to 10 to 12 by periodic small transfusions for these type of patients. If the more, the lesser the hemoglobin, the more will be the chance of iron absorption from the body. And these patients, as you know, require iron chelation because they are iron overloaded, and there will be growth delays. Restricted transfusions have lesser morbidity and mortality than liberal transfusions. Liberal meaning I'm transfusing keeping the cutoff of 10, and restrictive I'm keeping the cutoff of 7, except acute hemorrhage or unstable or symptomatic patients. Say patient's hemoglobin was say 14, but due to severe bleeding, the patient's hemoglobin has fallen to 9. In such a scenario, I will not wait for the cutoff to come to 7. If the patient is already hypotensing, because 14 to 7, so a lot, 14 to 9, a lot of bleeding has happened. So we will start the transfusion then and there itself. We will not wait for the patient to destabilize it further. So it's a clinical call again that how much bleeding has happened. That becomes an important scenario there. Attempt should also be made for autologous blood transfusions for planned surgeries with an expected intraoperative blood loss. That I know that okay, there may be a blood loss in the patient, and so there are scenarios where we collect blood from the patient before the surgery, maybe a few weeks before the surgery, maybe intraop also, depending upon there are certain scenarios, so we collect blood and we transfuse the blood back to them. So I mentioned Jehovah's Witness during the start of the talk. So this Jehovah's Witness, say suppose the hemoglobin is 10 and the patient requires surgery, I will prefer to collect the blood just before surgery. The hemoglobin will drop, and during the surgery patient bleeds with a hemoglobin of 8 and I'm transfusing the blood back to the patient of a hemoglobin of 10 value. Definitely when I'm collecting 1 or 2 units of blood during the surgery, I'm giving some saline to keep the volume same. That is called isovolumic normovolumic hemodilution. Normovolumic hemodilution, autologous blood transfusion. So for platelets, afebrile patients, not bleeding patients, cutoff is 10,000 per microliter, only 10,000. Normal range for a adult person is 1.5 to 4.5 lakhs per microliter. But for platelets, we have adequate, even 10,000 platelets patient will not bleed. So we have adequate physiological reserve available with us. So if febrile patients not bleeding, we wait for 10,000 count. For febrile patients or aplastic anemia patients, who even when they are not bleeding, we have to transfuse at 20,000 because platelets are more consumed in patients with fever. And aplastic anemias, again, there are some other issues available. For bleeding patients, the patient has started bleeding, or there is a surgery, major surgery, minor surgery, including LSCS, invasive biopsies, lumbar punctures, central line insertions. These are the common scenarios. So there the cutoff is 50,000. So if you get a patient with a platelet count of 1 lakh, don't start transfusing the patient just because a surgery is planned. We can easily avoid any transfusions till 50. Yeah, we should reserve platelets for the patient, that if something happens and the patient starts bleeding a lot during surgery or something because of artery injury or major organ damage or something which has happened, then definitely we should have some backup available because this patient has a higher risk of dropping from 1 lakh to 50,000. But under routine scenarios, platelets are required for transfusions for major surgeries only at 50,000 count. For retroperitoneal bleeding and renal surgery where compressions are a problem, we cannot reach out to the organ easily. So there the cutoff is 70,000 per microliter. Intracranial bleeding, CNS surgery, and intraocular bleeding. These are close-spaced bleedings and can lead to severe organ damage if bleeding starts there because the blood will compress the brain or the compress the ocular tissue a lot. So there we keep a cutoff of 1 lakh cells per microliter, 1 lakh platelets per microliter. For neonates without bleeding, the cutoff is 25,000. And patients, there are certain patients like immune thrombocytopenic purpura, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, heparin-induced thrombocytopenia. So these are some rare diagnoses, but these should be transfused only when the patients are having life-threatening bleeding. They're contraindicated otherwise. So if I get a patient with ITP at a platelet count of 10,000, I will not transfuse that patient because the more you transfuse, the more damage it causes. Even platelet is 9,000, 8,000, I will not transfuse. The more you transfuse, it will cause more damage to the patient. So such patients we transfuse only if the patient is having life-threatening bleeding. For fresh frozen plasma, non-bleeding, stable patients with deranged INR or increased PTA-PTT, no FFP. We are not giving FFP to correct the lab parameters. If patient is not bleeding, don't do anything. Don't we should not overtreat the patient. If INR is more than 1.5 or APTT is more than 1.5 times that of the upper normal range defined by the lab, and along with this, there is bleeding or surgery or invasive biopsy, you transfuse 1 dose of FFP. How much is 1 dose of FFP? We saw in the dosage screen, that dosage slide, that 1 dose is 10 to 15 ml per kg of the recipient. Each bag has 200 ml, so we calculate as per that how much is required for that patient. For APLA syndromes, antiphospholipid antibody syndromes, or any condition where APTT is not correcting. So there is a mixing study. Whenever APTT is increased, good labs will tell you, will do a mixing study in that where they mix a normal plasma to see whether there is any inhibitor there or not. So APLA syndromes or factor 8 deficiencies with anti-factor 8. So those syndromes where places where APTT is not correcting in mixing study, whatever FFP you give, it will not treat, and there is no requirement for FFP at that time because they have some inhibitors to that. Minor derangement of PT, INR is poorly predictive of surgical bleeding. It will not bleed. These are some published studies. BCHH is a guideline, British guidelines are available. So these mentioned that minor derangement, say 1.4, 1.6, 1.7 1.4, 1.3 INR, these patients will not bleed. So we should not try to correct the PT INR in such patients. Again, there are multiple studies in adults and children where INR was till 1.1 to 1.6 in adults and 1.1 to 1.85 in children. There they found that FFP failed to significantly improve the INR in majority of the cases, and there was no relationship in bleeding with bleeding. Cryoprecipitates. This again is a common question because you don't use it on a daily basis. So for bleeding patients, surgery patients, fibrinogen levels, between 100 to 150, which we discussed earlier, one dose of cryoprecipitate, those we have discussed earlier. Non-bleeding patients, fibrinogen value of less than 100 and at risk of bleeding, there we give one dose. Bleeding, surgery, and fibrinogen value of less than 100, we give double dose. So there is scenario, if a patient is fibrinogen value is between 100 to 150, but there is additional bleeding or there is an additional surgery, two things are combining, then we give one dose of cryoprecipitate. Finish. If a fibrinogen value is less than 100, that is, risk is there, but patient is not bleeding right now, we give one dose. If patient's normal range is 100, more than 150, so if it has fallen to 140, we will not give anything. If there is a double hit, fibrinogen value is less than 100, bleeding or surgery is happening, we have to give certain extra. So we give double dose of cryoprecipitates at that time. Our goals of transfusion is to treat symptoms, which include anemic hypoxia, which we read in our physiology, and bleeding, like PT, we give platelets, plasma for bleeding, and red cells for anemia. Anemic hypoxia. The reason, the utility of blood is just to bridge over acute events with capability to cause anemic hypoxia bleeding, like surgeries, injuries, DIC, infections, transplantations. We are never targeting to correct the actual value. Blood transfusions provide only a short-term increment of the transfused agents. It will not be that you have given adequate blood today and after 6 months the patient comes, it will remain the same. After 1 month the patient comes, it will remain the same. Platelets, the life inside the body is only 9 to 12 days. So if you transfuse, definitely within a few days it will again come down. So I'm not targeting to normalize the value. Never normalize the blood count which you are getting from the lab. Goal in some disease, actually the investigations will never even normalize whatever you transfuse. For example, in chronic liver disease, the PT, APTT, it will never normalize. Not every chronic liver disease patients bleed, correct? We have collected, I'm sure you must have removed some ascitic fluid, did some ascitic tap from a CLD patient to test it or to treat the patient. And the PT, APTT, even though might have been prolonged, the patient will not bleed. So patients do not bleed like that. And these patients, PT, APTT, they will not even correct. Yes, definitely, if you're taking the patient for a surgery during chronic liver disease, then definitely it's a major second hit. Then we have to transfuse the blood and do the surgery immediately. But we cannot say that first correct the PT, then only we'll give the incision. This will never happen. And I'm sure you must have heard that in dengue we transfuse platelets. But even after transfusion of platelets come down. We'll never be able to normalize it. Our target is, if the patient is bleeding, we give platelets. Patient is not bleeding, unnecessarily do not touch. And if the fever is there, our cutoff, we have some cutoffs, but again, that cutoff is not valid for dengue and specifically ITP also, immune thrombocytopenic purpura. These are the common guidelines. These are available online and can be downloaded free of cost. British Committee for Standards in Hematology. These are available. And there are certain studies again for which have helped in development of these guidelines. These are also quoted in these guidelines. And for children and pediatric, neonates, fetuses, even for fetuses, we have blood transfusions happening. So we have some cutoffs available, reasons available. There are studies which have shown that in GI bleeding or in cardiac surgery, restrictive transfusions were much better than liberal transfusions, and meta-analysis have been done from them. In different populations, these are available. So some take-home points are different blood components have different requirements. Their storage and transportation conditions are different. If these conditions are not met properly, they may cause more harm than benefit. So we cannot transport red cells with ice pack. We cannot transport red cells with platelets together in the same box, and all require an insulated box to be transported. Cannot be transported in a polythene bag or a usual sample transportation box. Should be a thick box where sunlight cannot enter, and it's a like opaque box. Sunlight cannot enter, and temperature does not fluctuate that much. Blood is an organ because it belongs to a circulatory system, and transfusions are equivalent to an organ transplantation. Earlier, we did not know much about blood transfusions. Animal blood were transfused to human beings. We did not have the concept of ABO. In fact, Karl Landsteiner got Nobel Prize because he identified, he discovered blood groups. Based on that, a lot of things have changed, and a lot blood transfusions have been made very safe. So before that, a lot of patients used to die of blood transfusions. Hence, blood transfusions have a lot of adverse effects inherent to it, as in other organ transplantations, and it's best if we avoid unnecessary transfusions. Uh, Definitely, restricted transfusions help, and wherever required, we do need to transfuse. Without transfusions, it's a double-edged sword. We do need to transfuse where it's required, but unnecessary transfusion should be avoided. Clerical errors and human errors involving incorrect identification of patients, samples, or blood units are the most common cause of errors in transfusions. Do not assume it's someone else's responsibility to check. If you are involved in transfusing, you verify it. Blood transfusions provide only a short-term increment of transfused agents. Goal is never to normalize the blood counts. In some diseases, the investigations will never normalize. Thank you.
Thank you for such a beautiful, elusive session, sir. May I request people to put forward your question, dear doctors, and you can either unmute and you can ask the questions, or you can put it in the chat box.
Sir, I have a question. After giving blood transfusion for any patient, so is there any time gap from the end of transfusion till we get a blood sample for doing repeat, CBC or any other biochemistry investigations? Any time cutoff?
Very nice question, doctor. So we should allow homeostasis to happen, and it's a good idea to wait 1 to 2 hours and then only collect the sample. 2 hours is more preferable. In case you need an urgent investigation, then you can send after half an hour, 1 hour. But I will suggest to get an unbiased report, because when you say, suppose you want a biochemical investigation, say potassium, and we know that RBCs can lead to a mild increase in potassium, because potassium is an intracellular element. So that can again lead to some minor changes. Hemoglobin definitely will change. Platelets will change. So it's a good idea to wait for 2 hours before we send another sample, if time allows you.
And in pediatric patients, suppose we have got packed cells for transfusion, and for the based on the weight we calculate 10 ml per kg the packed cells. Suppose if the baby is say 10 kg, and we need only 100 ml, but we won't get packed cells 100 ml. So at that time, what is your suggestion, sir?
So again, I like your question, and in our blood bank we have sterile connection device. With that sterile connection device, we divide the blood and we give to you in the volume you require, because so that it does not waste the remaining the volume. So my bag has, say, suppose I have 300 or 400 ml packed red cells in that, and you require 100 ml today. We issue the same 100 ml today, and we inform you that the remaining volume is available for your patient in my blood bank. It will be stored. When the patient requires the second unit, third unit, suppose, we will issue it from the same unit, and will not bill you again for the same unit. Maybe a sterile connection device, a few hundred rupees may be billed for you, but it will ensure that the entire bag is not billed, and the patient receives the same unit, so less exposure of multiple donors. But again, I agree, in many blood banks the sterile connection device may not be available. Only in good blood banks it's available.
Okay.
Also, because it's a sterile connection device, the shelf life of the blood does not change. So it does not become an open system. The tubings are, with the help of sterile connection device, tubings are connected to of one bag to another empty bag, and we give you whatever volume you require, and the remaining it's again sealed with a radio frequency sealer, and then it's stored.
Sir, in government setup, two babies requiring a packed cell, and maybe one packed cell we got it, and can we transfuse for the both the patients with the same group?
A nice question. So what you can do is, instead of you deciding it, you send the samples of the blood to the blood bank, telling that that decision, like planning the decision, it's a main thing of planning. You tell the blood bank, cross match it with both the patients, and they will give you the one bag. They will not have the sterile connection device, I'm understanding. If they're not having, you can transfuse it. You can split and divide, but the cross match should be done with the second baby also. Even though
Yes, yes.
The group is same, but we will request, because the blood bank will retain some samples for cross matching. We have segments, so from that we can cross match for 2 patients, and you can use it for 2 or 3 patients definitely. That's a very good way of thinking.
And
Sir,
transfusions for the second baby, we have to change the transfusion set, or can we use the same thing, sir?
So if you want 100 ml, how will you remove it from the bag? How do you plan? So if you cannot connect and then allow 100 ml to go, I'm sure if you don't have a cell connection device, infusion pump set may not be available. If infusion pump set is there, you can decide from that and give. That is one way. If infusion pump set is not there, you will have to collect it in 50 ml syringes, and then infuse it to the baby. Second way. And if you are using, say, suppose infusion set and giving 100 ml from that without changing uh, without collecting in the blood set, then you have to use a different blood set, because the IV cannula of the other baby will have some of blood stains from that baby also. So we don't
Okay.
want this baby's blood to touch the other baby. It's HIV things and all are common in India, na? So
Okay. Thank you, sir.
and how to collect blood from a blood bag into a 50 ml syringe. So there are 3-way stopcocks available, and then 50 ml syringes are available. So with the help, I'm sure you must be using the same stopcocks for exchange transfusions. So you can use that and collect the blood in that. Sure. Okay.
sir,
Sir, I have it.
Hello?
sir, I have a question. Sir, a diabetic patient receiving blood transfusion, how much HbA1c level will get affected after 2 units of blood transfusion, and when should we check it again to confirm the drop in HbA1c and also the blood sugar levels?
So one thing, HbA1c, it does not get
See, he is
affected.
a diabetic patient, right, sir, with HbA1c and but needing a blood transfusion. We transfuse the blood. Now, his hemoglobin level is coming up, but will there be any change in the HbA1c level because the blood, we have given the fresh blood accordingly, sir? Or
A good
will there be
question.
no change in HbA1c levels? That is what my
So
question is.
So HbA1c level should not change, but again, I have to refer again. I've not
Because
checked it.
this is one thing, because I've got a patient here which is um, uh, I have advised blood transfusion level, but again, has to go for surgery. HbA1c level is there, so we were just contemplating when shall we look for HbA1c level checking after 72 hours or 48 hours once the transfusion is done, hemoglobin level is up. Shall we check the HbA1c level, modify the medicines accordingly, check the blood sugar levels also, or shall we not refer the HbA1c level at all, and again wait for 3 months or 1 month after blood transfusion to check on the HbA1c level, how is much it has affected the fresh blood which has come?
So HbA1c.
Because there is no literature available on the
Yes,
net. We tried to
yes,
find out, but we couldn't
yeah.
find out that.
So very good question and a genuine question. So it's best to check the HbA1c before you start the transfusion, so that you
Agree that
get a
because
baseline.
see, there's a person is going for a operation. He's there for a he's a cancer patient going for a since they have to transfer the blood. HbA1c level been checked before that. It is 7.1. Blood sugar is also 200. We're going to put the chap on the insulin before we're going to check it. But once the blood transfusion has been done, once his thing and hemoglobin level has come up to us okay level, when should we check the HbA1c level? So after
I,
three,
yeah, I understood
after
your
a
question,
month,
doctor. So I understood your question.
or after 15 days? I don't know. That is what we have not been able to find out.
So
How
yeah,
much drop is going to be there in HbA1c level?
so let me tell you the answer, doctor. So there are a few things in this. One, the best time to check is obviously before transfusing the blood, so that there is no
Absolutely right,
discrepancy
sir.
come. There is no discrepancy happening. Now
Mm,
HbA1c of the donors will also be there in this, which will be
mm,
contributing in your value. So donor
mm,
1, donor 2, donor 3, there may be multiple units which you are giving, and blood donation is allowed for diabetics. Diabetics,
exactly.
yeah, diabetics can donate blood, and unless until they're on insulin or end organ damage is there.
Mm,
So
mm, mm,
HbA1c may fluctuate a bit. So we should not check after the transfusions is done,
mm,
because the units may remain in the body for more than a month. So
mm.
So we should not check. And I did not get the point why we should check HbA1c at all for changing the insulin levels, because for that we should check fasting or PPBS rather than HbA1c.
I mean,
HbA1c
why?
is for
Because
HbA1c.
after the onco surgery, after 1 month, shall we check the HbA1c to check for any change in the HbA1c level so that his diabetic treatment can be modified accordingly, or shall we not? That is the thing.
So what I say is, if for modification, is there any like for in this particular patient, is there any what to say issue whether the patient is not taking regular medications, or some issues are there not? In case it's not there, then you can even like omit HbA1c check for some time. Better to check it after 1 month is minimum. The red cells will stay in the body, so
Okay, sir.
better to check it after 1.5 months. And
Sir.
definitely post transfusion we should not check. Whatever to be checked, baseline only. And
Right, sir.
modification of medications immediately post transfusion, like, should be based on your other parameters rather than HbA1c before surgery.
Okay, sir. Right, sir. Thanks, sir.
Thank you.
Sir, I have a question. When we have a transfusion reaction, we stop the blood transfusion. Should we send the sample back to the lab to recheck? Are there any concerns or guidelines which
Yeah,
mandates all this?
Yeah, so there are. What I will do is I will ask Dr. Soumya. We can arrange one more session, because transfusion reactions is another session. So it's a
Sure,
full
sir.
packed session. So because there are different type of reactions on what you should do, what you should not do, what pre-medications, what post-medications. So we can have one more session based on only on transfusion reactions one day.
That would be great, sir. Thank you so much.
Thank you.
Sir, I have a question. Hello.
Yeah, please go ahead.
Sir, in pediatric patients, after transfusing 100 ml from one pint of bag, can we send it back to blood bank and reuse it tomorrow, next day?
Yeah, so till 24 hours we can do that. It becomes an open system, and if we are ensuring that the blood sets, the end which goes inside IV cannula was not contaminated, and we are keeping it proper, it's covered again with some cap or something, then we can send it to blood bank. Blood bank requesting them to store it for 1 day, and we can take it again within 24 hours. We can use it again. So 24 hours is the life expiry shelf life after spiking the bag. We can easily do it.
Yes, sir. Thank you. Thank you.